And do you call an ascites refractory? A refractory ascites is a situation where the ascites can't be mobilized or can't be prevented from recurring despite medical therapy. This can be divided into two types. One is the classic one, diuretic resistant ascites, and another one is diuretic intractable. So let's first talk about the diuretic resistant ascites. Diuretic resistant ascites is an ascites where you give the maximum dose of diuretics, but the ascites still is not mobilized. And the diuretics should be given for at least 1 week with a salt restricted diet where salt is less than 5.2 grams per day. And what is the maximum dose of diuretics? The maximum dose is Spiro for 400 milligrams per day and furosemide 160 milligram per day. And this is defined as a decrease in weight less than 800 grams over a 4-day period. Urine output of sodium is less than the intake of sodium, because with diuretics we expect a lot of sodium to go out through the urine. So urine output should be more than the intake. But despite diuretics, here the urine output of sodium is less than the intake. And if the ascites recurs within 4 weeks, those are the indicators that suggest that the patient has a diuretic resistant ascites. What is diuretic intractable ascites? Diuretic intractable ascites is an ascites where the patient can't tolerate the effective dose of diuretic because of some side effects. So we can't use the diuretic. The patient cannot tolerate the diuretic. That is diuretic intractable. Now let's talk about the management or treatment of diuretic resistant or diuretic intractable ascites. The management options are large volume paracentesis or LVP, transjugular intrahepatic portosystemic stent shunt, peritoneovenous shunt, drugs such as metodrine, procedures such as alpha pump. And obviously, the best treatment for most of the patients would be transplant. So first, large volume paracentesis, that is the first line therapy. And in this therapy, we actually we tap at least 5 liters of fluid. But this high volume of paracentesis can lead to a paracentesis related or paracentesis induced circulatory dysfunction. So to prevent this, what we do, we give albumin infusion 7 to 8 grams per liter of fluid tapped. And if a patient requires LVP for more than 4 times or at least 1 to 2 times per month, then the patient becomes a candidate of TIPS. And the commonest complication of TIPS is hepatic encephalopathy. And if the patient cannot tolerate TIPS, then another option is a peritoneovenous shunt. Additional treatment may include metodrine, which is an alpha-1 agonist drug, and it improves renal perfusion. It causes vasoconstriction and improves renal perfusion. Alpha pump is a procedure where a subcutaneous pump takes out the fluid from ascites on the peritoneal cavity and pumps it to the urinary bladder. And obviously, if all those fails, the only option remaining will be transplant.